On behalf of People's College of Dental Sciences and Research Center, I welcome all of you on this e-learning platform, and I welcome Dr. Anuj Bhardwaj, specially, who joined us from Indore. He is an eminent endodontist and has been working in the field of microendodontics for quite some time now. And I especially thank him on behalf of People's College of Dental Sciences and Research Center, and I thank him for accepting our invitation for taking this e-learning program for us. Thank you, and thanks a lot for being with us today. I hand over to Dr. Pankaj to kickstart the program on behalf of Department of Endodontics and Conservative Dental.
Hello, good afternoon, sir. Dr. Anuj Bhardwaj, sir, welcome, sir. Sir is a BDS, MDS in Conservative Dentistry and Endodontics. He is currently working as a professor in College of Dental Sciences and Hospital Rao, Indore. And sir is also an adjunct faculty, Department of Conservative Dentistry, Universitas Erlangga, Indonesia. Sir was Chief Coordinator for East and Central India of Root Summit 2014 and was also the reviewer in the reviewer panel of PubMed Index Journal, which is Journal of Conservative Dentistry. Sir was Executive Committee member of Indian Endodontic Society for the year 2014-15. And sir was Organizing Secretary for 4th West Zone IESPG Convention in 2015, which was held in Indore. Then sir was Associate Editor of Endodontology Journal, a publication of Indian Endodontic Society in the year 2015-16. Sir is currently an Executive Committee member of Indian Endodontic Society for the year 2016 to 2021. Sir was pre-conference chairman for IDC in 2019, which was held in Indore. So I would like to welcome sir, and we will just kick start the program. So sir, please continue and share your knowledge with us, sir.
Okay. Thank you for this wonderful. You can hear me, right? Am I audible?
Yes, sir.
Okay, perfect. Thank you for having me here. A very good afternoon to all of you. I'm Dr. Anuj. I would like to thank People's College of Dental Sciences and Research Center, Bhopal, for having me here. And I would like to thank the Chief Patron, Mr. Suresh N. Vijayvargi ji, Co-Chief Patron, Ms. Neha Vijayvargi and Mr. Rohit Pandit, Patron, Dr. Rajesh Kapoor ji, and University Advisors, Dr. V.K. Pandya ji and Dr. Neerja Malik ma'am, and in this institutional advisors, Dr. Pramila Tyagi ma'am, the Dean, and Dr. Swapnil Parlani, Vice Dean sir, and Program Chief Coordinator or the Chairman, Dr. Manish Agrawal sir, who is the head of the department, and you two, my good friends, Dr. Santosh, Dr. Anu Narang. And above all, I would like to thank my dear friend, Dr. Darpan, for having invited me for this, and a very good and a sweet student who is working along with you as a colleague, Dr. Sushil Krishnani. So before I start off, I've been given this topic of microendodontics. I had plans of talking about magnification in per se in all the branches, but then as the topic has been given to me on microendodontics, we will be talking only in per se of endodontics. So this is one saying which I always like to put across when I start any presentation in magnification. You can only treat what you can see as given by Professor Singhuk Kim. Now, what is the question behind this? Why we should adapt to magnification? First question. And once we have adapted, or people who have not adapted, why don't they get into magnification? What is the reason, and what is the edge in practice if we are using magnification? This is another thing which you need to, these three questions have to be answered by the end of my presentation. Like, why should we adapt to magnification? Why are people who are not getting adapted to magnification? And if I have magnification, how my practice or how is my clinical skills or acumen going to increase with this? So let's focus on seeing, because dentistry is all about seeing. And to our knowledge, you should know that if any two dots which are kept 0.2 mm apart would look like a single dot, just as one dot, because that's the resolution of our eye. And whatever things we are dealing in dentistry are all, especially in endodontics, are less than 0.2 mm. So what's the need of the R? I want all of you to pay attention to this image, not just because it's a Indian currency note, but I want you to remember what is being shown to you here, because as we progress during our presentation, we would be getting a better insight of what is being shown to us here. So magnification is all about seeing and trying to improve the resolution of our eye. So if you see here, unaided vision can give us a resolution of 0.2 mm. Whereas when we go higher in magnification, like 10x or 20x, it becomes 0.020 or 0.010 mm. So that means your eyes are getting better vision and you're able to see minute details like cracks, like any debris which has been there, any GP which is left over, or any instrument which is broken. These are the things which are not able to be seen by our naked eyes. And even if you're using magnification in the method of uh, loops, you don't see it as well as when you see it under microscopes. Most of the dental colleges in India have microscopes, but they're kept in one side, and students don't want to use it. What could be the reason behind it is, again, we will be coming sooner or later. Now, what does magnification do? So if you see the image here, which I had shown you initially, this is again under magnification of 3.4x. As the magnification is increasing to 21.25x, you can even see the pupil of the eye so clearly here. So this is in our Indian currency. And one more thing which you need to understand is, as the magnification increases, the field of view is going to reduce, and that much more finer or minute you have to be in working while doing your magnification work. So that plays a major role when you're doing this. So when we talk about dentistry, okay, again, I get back. When you talk about dentistry, you need to understand that what is seen to our naked eyes is just a tooth, and we see different discolorations. We take a DC-16, we try probing, or we take a explorer, or we take a probe and try probing. But if you see it under highest magnification, or a magnification which is as high as 16x or 32x, you know what is just a discoloration or which is a dental decay. So if I am using such high magnification, I would use ultrasonic tips, or I would use minute tiny burrs, and I would just remove this decay and restore it. The rest would be just a fissurotomy, nothing more than that. It's not needed to keep drilling just because you see something discolored there. You should be able to identify what's wrong and what's right. So where is the problem and what's the solution to it? See, we have the eyes to see what is required, but we do not have the magnification or the resolution of an eye to actually know the fineness of what we are doing. So if this is not enough, which we need to understand is, as we age, we have something called as visual acuity. What happens with this is, initially, when your eyes are young and you are young, you're able to have a focal point exactly at the retina end. But then as you grow older, you have your lens aging and it stiffens, and your focal point goes behind your eyesight, behind your retina. So what happens is, if you see elderly people, they try to move away from the object to see the image clearly. So if this can be rectified from younger age itself, that it does not progress into this, it would be magnification. It would help us see things better even as we age. So now let's not just give presumptions. Let's go with some justifications and some articles which justify what we are saying. So if there's this one beautiful article from Swiss Dental Journal which talks about visual acuity and magnification devices. In this, they have collected nearly 214 articles and they came down to only 15 articles. And the conclusion of this is younger dentists would profit more from ergonomic aspect, while the dentists over age of 40 can compensate their age related visual deficiencies when using this type of loops. Whereas the optical advantage comes at a cost of ergonomic constraint due to the weight of the loops. The microscope is highly superior visually and ergonomically, and it's indispensable for visual control of endodontic treatment. So this was from Swiss Dental Journal. Now let's talk about a journal from Indian Endodontic Society or our Indian Endodontic Federation, which is Journal of Conservative Dentistry, and it's an article published from Department of Conservative Dentistry and Endodontics of Manipal College of Dental Sciences. Here they talk about is evaluation of tooth preparation of class 2 cavities using magnification loops among dental interns and final year BDS students in preclinical laboratory. So what was the conclusion they came to was magnification loops have significantly enhanced the quality of cavity preparation done by final year BDS students and interns during preclinical dental educational work. However, this is the most important conclusion. More practice with loop is needed for convenience of its use. So why people don't use it is convenience of use, because they have not practiced it enough. They get irritated and they say, okay, let's not use this. I can work well without it. Ergonomics. This is one image which I've been using from last 10 years, and I never thought that in this coming year of 2020 we would end up wearing these jumpsuits and something like we would ourselves look like astronauts. Jokes apart, if a device is given to us which will help us keep our backbone or spine straight, I am sure all of us would be ready to accept it, especially senior dentists or of late even junior dentists who are doing a post graduation. Half the time they take leaves saying that they have got back pain or neck pain or they've got cervical spondylitis. So if they are getting into the habit of magnification, not only in post graduation, from their third year BDS or once they get into preclinicals itself, things would get better. And even in preclinicals, if they work under magnification, whether it's a loop or a microscope, depending on which university we are under, at least a loop would help us to keep our posture straight. So if you see here, my posture is still straight. I'm not bending towards the phantom or the mannequin, and I'm still working adequately how it's required. So what exactly does ergonomics mean? It is a study of people's efficiency in their working environment. And there have been lots and lots of studies published which say that if you use magnification or any magnifying device, these commonly associated disabilities like cervical spondylitis or back pain can be avoided or it can be reduced. Now, to your surprise, it would be wrong on my part if I say that only Indian dentists have this problem. This is faced by all dentists all around the world at various age levels. But the point to remember here is this article was quoted in 1998. From 2008, American Association of Endodontics has made it compulsory for their postgraduates to use magnifying devices, that is your microscopes, to pass their masters. So why aren't we doing this? There are people who are just sleeping about it. They are just talking about it and they're not interested in making things move ahead. Even our own postgraduates think that it's a burden, who's going to get into it. But to your surprise, let me put this question to anyone who has been practicing in their final year or their internship or any postgraduate or any general practitioner or a specialist practitioner. Few of them at the end of the day or few of them even from their first patient are in this position. So being in this position, who can stop your neck pain and back pain? I don't think anyone can help you with that. So the person who's behind this is just you, no one else. But then we have people who have magnifying devices. On the right, you can see me working with a magnifying device. And on the left, you would see one more person with the magnifying device. He is still not working in a proper posture or he's not working ergonomically. So the problem is making sure that all this is put into process of working, and you work ergonomically, and you work in a zone where things are more smooth for you. So again, the problem and the solution, we need to work towards it. And let's make a start. If you see this image from an article, it's using an ENT microscope way back in 1917, if I'm not wrong. Things have changed, but the practice hasn't changed. Same thing goes with evolution of rubber dam. This was started in 1864, but people are still thinking twice to use it. So how can I ask people to go for magnification? And magnification and rubber dam always go hand in hand. I do not want reflection from saliva, or I do not want your tongue or cheek to be cut when I'm working under microscope. Because as I told you, as we increase the magnification, the field of view is reducing. So I do not know where the tongue is, where the cheek is. So I have to make sure that I isolate well, and I am in control of what I am doing to the tooth. So in clinical practice, not from social media, but then why this magnification is needed. Now, first point in magnification, why I always tell my students, my colleagues, my friends, seniors, juniors to get into magnification is because they can see better. And if you are able to see better, you can diagnose things better, which your colleagues or your friends are not being able to identify. For example, if you have a patient who's been walking to you every 6 months for a checkup, and after every 6 months you say there is a decay, there is secondary caries, or is there something which is happening, the patient doubts your capability. He says that you asked me to brush daily, you asked me to come every 6 months for a checkup, but still you're not able to catch hold of the problem. So half the time we are not able to see the problems. So if you have magnification, you can see them better, you can diagnose them better, and make sure the patients who are responding to you come back to you with less consequences. Your social standing, people look up to you for your treatment, they send cases to you. And once these things start happening, you get better ideas, you get better anticipation and interception of disease. Along with this, you are able to document well. And this medical legal cases coming up, we have to make sure that we document whatever we are doing. The patient does not complain saying that this was the condition of the tooth, but this is how the doctor spoiled it. So we have documentation from starting till end how we have done it. But most importantly, with documentation along with your medical legal issues is you are able to show it to your colleagues, and above that you are able to show it to your patient. So if a patient walks to me that you have been referred for an instrument retrieval, I do not turn on my YouTube, or I do not turn on my sketching pen and paper, and I don't show them that this is how I'm going to do it, but I just to my old case records, put on the video, put on the images, and show them that this is how we went along doing this case, and this is how we got success. So the patient is also impressed, and patient wants us to do the treatment rather than believing those graphical diagrams. So for me, magnification is future. What I would say, it's already the present. Leave the future. So what is the goal of using magnification is we have to pull each other and make sure that we end up doing complex cases in a very easy manner. I'm sure all of us who are seeing this presentation or this YouTube live would want to have such images or such kind of treatments done by them, so that they have enhanced skills, and patients and their colleagues look up to them when they're caught up in something. So how does this happen? This happens when you have enough knowledge about magnification. And first of all, I need to open your mind with magnification, what all it can do along with your knowledge. Just having a microscope is not enough. You should have the clinical acumen along with it, and you should have enough practice with it. But you need to practice along with the microscope. So getting into the clinical practice of endodontics, as my topic has been dedicated to microendodontics, I would not be talking about any aesthetic work here. So talking about any extra canal or MB2, how do we search for an MB2? We know we have to draw a line, we take a ultrasonic burr, or we take a Allen burr, we try running it through distally from the mesiobuccal one to the palatal canal. But We know it's here, but we don't search it ideally. We just take our burrs and run through it. But what you need to understand is, if you see this video here, I will be showing you how to trough for an MB2 and a distobuccal 2. Here I'm just using a straight forward contra-angle handpiece, slow handpiece, and I'm using a Messinger's burr. And I'm just troughing between mesiobuccal and a line which is traced to palatal, and I know exactly where to trough. I'm using a lesser magnification to show you how it's been done, so that you understand that you just don't work blindly with ultrasonic tips or your slow speed handpieces. You are supposed to see where you are drilling and how you are drilling. So if you see the image on the right, you would see an MB1 and MB2. Now, what is more important here is you need to understand that they are having confluence even at the orifice. So if I did not have magnification, what I would do is I would keep packing debris here, make two GPs look wonderfully well in the X-ray, and this patient would come back to me after 2 to 3 years, or sometimes even 6 months if the infection is still active, and you would say the X-ray looks wonderful, but what is the mistake which I did? It was nothing but
Sound चला गया
you can hear me? Hello? 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 Am I audible?
Yes, we can hear you, Anuj.
So I thought there's some.
Sir, we can hear you, sir. Continue.
Yeah, I would continue. Yeah. So I need to understand how the. Okay, can I have some silence? Yeah. Perfect. Okay. So now even when I'm looking for a DB2, I know where exactly to look for it. See, I am not scraping more than, or I'm not using any what you call extensive removal of tooth. If you see here, see what happens here when I'm showing it to you on an image is, it's a three-dimensional object which is being shown to you in a two-dimensional image. So you would not understand the depth. The DB2 is at a higher depth compared to your your DB1. And if you see here, the amount of dentine removal I have done is as minimal as possible. So even if I did not find it here, then I would move more palatally. I need to be as conservative as possible, and I'm supposed to make sure that I do not perforate the floor. That's very, very important for me when I'm doing any work under magnification. Especially in cases of mandibular molars, we've always been told look for middle mesial, look for middle distal, but where to look for it? You need to look first and foremost, take your ultrasonic tips. If you're working with your naked eye and your mouth mirror, you do not see anything inside the tooth. But if you're working with magnification, you see here that this is your mesiobuccal, this is your mesiolingual, and this was the dentinal lip which I have removed, and I can see this clear dentinal line here. And if I have to look for a middle mesial, I would be searching here, which I don't see. I don't see that any signs of having a middle mesial here. Same way when I go for a middle distal, this is your distobuccal and this distal lingual. Again, I have cleared it well. I have removed the dentinal lip. And to people like me who started post-graduation initial days, I could not even locate canals. But then with time, with practice, with magnification, I am able to see what most of us can't see even with magnification, because that's how you keep improving, and that's how you keep anticipating, and that's how you know how much to remove and how much to leave. Now cases like these, this is a mesiobuccal which has got a comma shaped or an eye shaped with a lascara, or it's a shape which what people would do is would take a orifice opener, make one orifice here MB1 and make one orifice here MB2, pack in all the debris. If you remember 4 slides back, I was talking about MB1 and MB2. What usually we do is we pack the dentinal debris or the necrotic tissues in between. I would get a beautiful RVG. I would get beautiful lines to show to my patients, to my colleagues on social media. But when the patient comes back, that is what I do not put on social media. And that is what is going wrong. See, more than social media, you need to understand that the patient is comfortable and the patient is happy about what's been done. So you need to understand that you need to respect the anatomy. When I know the orifice is this shaped, I would not be using any round file. I would be using an anatomical file, whereas I would be using a shaper here. So let's begin with few cases which we need to understand. So if this RVG is shown to you, what would you be anticipating? You would be anticipating, as a beginner, as a first year or a second year postgraduate, there is a single canal. Or as a third year, you would say, okay, there are two canals which are running parallel. It looks more like a premolar. One's going to be buccal and one's going to be more palatal. So that's exactly how it looked. See, one buccal and one palatal. But then with magnification, what we do is what we've read a champagne test. I put in sodium hypochlorite there and wait for the effervescence. So I would slightly forward the video and show you more of effervescence coming out from this region. So this is my buccal, this is my palatal. I have a strong doubt that there is every chance that I would have a distobuccal here. But when I have done my orifice opening, if I go back to my last slide, dental map does not show me that there is any deviation here. It just looks like one straight line. So what I need to understand here is I need to trough the orifice itself and go deeper, and this is where I would find my mesiobuccal, and this is where I found my distobuccal, and palatal is somewhere here, hidden. And when I had opened it up, I could see palatal here and buccal here. And when I did my effervescence test, I realized that there is some amount of pulpal tissue in the isthmus where I need to see it dividing into two so deep down. Without magnification, I am sure you could have found it, but in not this clean manner by just preparing it so minimally. I hope you understood the point here that with magnification, I know that yes, there is another one, and I can work so conservatively that I get to see the second canal opening so deep down below. There's this another case where this has got decay and the floor looks totally rough, and it looks more of calcified. Now, once you read Ingle Cohen, you understand the laws of color change. And you need to understand again how much to dig in. If you see this image on the left, there's so much of debris, so much of tissue tags which are there. And as I go deeper, it's very clear to me which is enamel, which is dentin. If you see the arrow marks, I'm showing you the color change, which is enamel, white color, which is dentine, which is brownish to yellowish, and which is calcification, this shiny grayish part. And I go more deeper and deeper, it's going to be grayish to brownish, more dark in color. And that's going to be my pulpal floor. I need to understand how much to dig in and how much to dig out. And in this case, I want you to understand even the palatal. Half the time we just take a round burr and round file and go ahead and prepare our palatal. But if you see here, this is a bean-shaped palatal canal. How do you expect me to just use a rotary file here, just in the center, create a bore, pack in debris here, and obturate it? In the RVG, it looks well. But then, who would clean this for me? Who would clean this for me? So once I am able to identify the orifice's shape, I know which file system to use for it. I would not go for something which would work only in circular fashion. I would want something to work in 3 dimensions. A case like this is a case which most of the times a final year PG or a second year PG who's going into a final PG would want to have to do apexogenesis or apexification. In this case, I went ahead for doing apexification. But how do I go about doing this apexification is I do not work blindly. With magnification, you see this periapical tissues? These are periapical tissues. So I know how much deep, in this case, I would not be even using a color coat to give a foundation for putting my MTA. I know how much of pressure and what length I need to apply and how much of MTA will be enough to be packed upon on this periapical tissues, and then I put on my putty material. So it's that easy. I would not have any extrusion as well. So today I'm just trying to open your vision and trying to make sure you understand what all can be done with magnification, rather than just flaunting my cases that I did this, I did that, even you can do this. It's not about that. It's about you people understanding, especially the postgraduates or graduates who want to get into the field of magnification, that once things are visible to you, it becomes more easy to work upon. Another case which I like to talk about here is this is a calcified canal. See this? It's totally calcified. Now, how do I go about working here? If I see this, there is some amount of canal seen here, the radiolucency here and here. And if I see my CBCT findings well, like here, the apical exit is here, not at the radiographic apex. So all these things have to be paid attention to. Read the CBCT well. Along with reading the CBCT well, I go ahead and isolating the tooth, go ahead giving a punch cut right in the center. If you remember the diagram which was drawn in the CBCT, that the canal is right in the center, and I would find it in the middle and apical thirds. So I give a punch cut, make sure, see, I'm not using any hi-fi device, I'm just using a straightforward erotor and a front surface mirror. I just like to keep it very simple. Now this is your Messinger burr or an Allen burr if you want, with a slow hand piece, and I'm going exactly along the long, parallel to the long axis of the tooth. And now I would want to see the color change, the enamel, dentin, and the calcification. And now I take a 10 number file, try giving a watch and winding motion, and see, if you see here, I could negotiate the canal. Then we did our PMP and we went ahead and obturated it. So if you remember the CBCT which I showed you initially, the anatomic apex and the actual apex are not coinciding. So it opened up here, and this is the apical puff which we are having. So even in this conservative micro axis which I did something wrong. And what was that? It is this much of excess enamel and dentine which I have removed, just this much. So if I'm working with magnification and if I'm working accurately, I would not have even removed this. So you need to understand that you anticipate or you correlate your CBCT along with your magnification when you're working. So this turned out to be a good case. We finished it well. Now cracks. There are so many cases which come to us with cracks, and we end up obturating. Patient still has pain. You need to understand that yes, how deep the crack is going, whether it's going to the pulpal floor. Not every case would be ready for going for a CBCT. So if you take a picture like this and you show it to the patient, see, it is not possible to save the tooth. This is the reason for this is the crack is propagating down to the floor, and you have enough documentation, the patient understands. And even if the patient does not understands and goes for a medical legal issues with you, you already have enough proof to show that yes, this was the reason that I did not anticipate this, and I said no for doing a root canal in this tooth. In retreatment cases, if you get a case like this where there's a crown, we split dam, give a buccal groove, remove the crown by wedging it, and then penetrate the old restoration inside. And when you see so much of temporary cement inside, you understand that there was a half job done. And if the GP comes out easily and less sealer is there, it's a good sign that you would have more of a virgin canal to work with, and things would become easier for you. Things would get easier for you. Unlike in cases where people end up obturating halfway through because of causing multiple ledges and multiple mishaps, elbows. So in this case, it was comparatively quite easy for us to clean the GP, make sure the orifices are clean, the canal is clean, we dried them enough, took our master cone X-ray, went ahead and did our continuous warm compaction, and always take angulation in angulated X-rays to see if whether the canals were merging or it's just a thing which was looking to you. And this can be correlated even under magnification. Another case here, if you pay attention to the radiographs which are given to you and the crown given, if you see this, there is a pulp stone. Because of that, they did not have good entry to the orifices and they worked halfway through. And there is this one instrument which is separated there. So, what do I do first? Refine the axis, remove the pulp stone, and then go ahead and try bypassing this instrument. Because when I'm working under magnification, I see this instrument here. It is present in the what you call in the lingual aspect of the mesiobuccal canal, and if I cut more dentine here, I have more chances of having a strip perforation. Yes, I know I can use MTA, I can use MTA putty, I can use different techniques to seal this perforation, but then if I can save this tooth without removing this instrument and I can bypass it, which I've already done, giving multiple dressings and making sure that the periapical lesion is towards healing and the patient is totally asymptomatic, and I know I can avoid the strip perforation, I would go ahead and obturate. And I've used bioceramic sealer here, and the patient's still doing well. It's been more than 5 to 6 years that there is no complaint from the patient. So even just having the gadgets, having the ultrasonic tips, microscope, having the skills of removing the instrument, you should know when to leave it and when not to leave it. For instance, a case here, this case came to us in 2018, if you see on the left, and there was some amount of periapical lesion, but it wasn't significant enough. Patient was asymptomatic, so patient was told, okay, let's keep it on hold and let's see you after 6 months. Patient came back to us after a year, and patient was symptomatic. So we sent them for a CBCT image. So when we took an image, if you see here, it had such a huge lesion touching the floor of the nose or the nasal floor. So we ended up exploring this, and when I explored it, again, I would not show you videos or images showing you that okay, this is how we did it, but it is basically for you to understand. Even if there are four, there looks to be two instruments, but there was one, two, three, four. So there was one and two K files, one rotary file, and one ultrasonic tip. So someone has already tried all the gimmicks to remove it, but they were not successful in doing it. But then, if you work under magnification for more than 400 hours, I would say 400 hours, that is, even if you work for 4 to 5 hours a day, and for a year, if you work with all the other duties which you have of OPD, special cases, LDs, JCs, seminars, thesis, I'm sure by the time you finish your post graduation, you would have your tiny movements of hand, which is the most important thing when you work under magnification. So this is how we removed them and we obturated, and the patient is doing completely well. Now this case, which was a endoperio lesion sent from perio department when I was working in Arvindo Hospital, and there was this broken instrument there in the radix canal. So I told my student to go ahead and put it under the microscope, look for it. See, even here, even though the quality of image is not good because they do not have any documenting device. So in the C mount, we put our phone and tried captivating it. So we could see here this triangular cross section that it's a pro taper. And I made sure that my student does this and she could remove the instrument. The only thing which went wrong here is the small amount of instrument which is left behind. But then when they did perio, they made sure that this was all out. So there were 3 mesial canals and 2 distals and 1 in extra root. So this turned out to be a good case for our student, and the student could remove it even in the first attempt, because you need to understand the distal canals and the palate canals are huge and you have enough space to work around. And this you would understand once you start using magnification, once you start getting a little irritated with magnification, that why I'm not able to see, how do I make things clear. Once we sit down and work, I will teach you how to make your life more easy under magnification. Today, I'm just trying to open your vision to see what all can be done by you under magnification. Now, there's another case which was referred for instrument retrieval in the distal canal. We could retrieve it, and how did we go about doing it is, first we removed all the caries, did a pre-endo build-up, went ahead and located for the canal. If you remember, I told you in the distal canal, you have enough space to work in the buccolingual direction. So we could hunt for the canal here. We saw this canal, and then With ultrasonics, we teased it out, it came out. But then this was a case which I did 7 to 8 years back. The outcome of removal of the file was good, but removing so much of dentine is bad. Because for now, if I'm doing any case of instrument retrieval, I would not remove so much of dentine and would not want this tooth to fracture off sooner or later. This case in which again distal canal, the file has gone beyond the apex. If you see, we took CBCT to just know where exactly it is, how far it is from the your mental foramen or your mandibular canal, how far is it from the nerve. So we could locate it under magnification. First step, what we did was removed all the caries, pre-endo buildup, orifice enlargement, packing the other canals with calcium hydroxide, then going ahead and working in the distal. Took a file, tried bypassing. I always try bypassing it just to see if there is enough space around it for me to work. Once I have bypassed it, I know that there is some space. Use my ultrasonic tips, create a staging platform, make sure the instrument is seen by me, remove 1 or 2 mm of dentine all around it so that some amount of the instrument is protruding outside. Try to use my ultrasonics in anti-clockwise direction so that the screwing in effect of the file, which is in clockwise, becomes little loose and we can get the instrument out. So what went wrong in this case that the instrument broke here is what we need to understand. So I would like to show it to you here in this video. Is this is the reason exactly here. So this was the extra exit created by using a file with a lot of apical pressure. Whenever we teach you rotary, we say that don't give any apical pressure. Create a glide path, let the file move in slowly and up and slowly inside out. But what we do is, as a beginners, we give so much of pressure that it creates its own apical exit. But the exit was here. So the file broke in this due to cyclic and torsional fatigue. It's a combination of both here. So this was the apical foramen, not this. This was the one created by the referring dentist. Now we've spoken about getting extra canals, orifices, looking for extra canals where and how to look for it. The people who say that during biomechanical preparation I do not need magnification, but my answer to them is no, you need it. Now this is the anatomic file which I'm using, where I'm trying to clean and shape the mesiobuccal, distobuccal, and palatal. And what will be evident to you is once I start zooming in is the amount of effervescence still happening in that canal. That means that there is some amount of pulp tissue or necrotic debris which is being packed there. I have to make sure that this bubbling action stops and I have clean canals like these or like this. Unlike this, see, if you see here, there is again bubbling action happening. That means there is some amount of tissue or necrotic tissue which is still left there. So I have to make sure I get orifices or chamber or the bubbling action zero, like in these canals. Only then I'm quite confident that yes, whatever I've done is up to the mark. If not 100%, at least 99%. And there is one more school which talks about why do you think we need it in obturation? Obturation again is a blind procedure. And most of them, what they do is they coat the canal just with their GP point. I prefer using a paper point. Whatever the master cone size was, I take my GP point, try giving this puffing action, and try making sure that all the surfaces of my canal are coated with the sealer if I'm using any resin-based sealer or any zinc oxide-based sealer. If you see, I'm trying to magnify into the canal and the canal is coated. Then I take my master cone, again coat only the apical thirds, place it, give pumping action, take it out, give this gentle pumping action that I don't want to create any pressure. And then I take my touch and heat element and shear it off at the orifice. And a lot of people who say that they did warm vertical compaction by doing only this much. But this is not the way how you need to do it. It's not just about shearing it off there and just using a condenser and packing it up at the CEJ. This is not your continuous wave compaction. What you need to do is you have to keep a stopper which is 5 mm short of the apex and remove all the GP in the middle and the coronal thirds. See, I'm doing it in pecking action. I would take it there, leave it, heat it, remove it, and then I would go ahead and start packing it. And even the plugger selection is most important. The plugger has to reach at least 5 mm short of your apex so that you can actually condense it at the apical thirds. Once this is done, I would move ahead and take, so sorry, okay, so sorry about that again. I would condense it and then I would take my backfill and fill it back. So now this is how you need to do continuous warm compaction. Next thing is your cold hydraulic obturation. This is a new method of doing obturation where we use bioceramic sealer. Here what we do is, again, if you see my syringe here, I have a stopper which is giving me the indication how short of the apex I am. I completely fill the canal with bioceramic, coat my GP on the apical thirds with bioceramic sealer. Here it is more of the sealer and less of the GP. So I'm trying to break open the bubble which is there to make sure that the whole sealer gets in through. Now I shear it at the orifice. See, I'm checking for the tug back, trying to make it clear for it to be visible to you. I would take a touch and heat, remove it from the orifice, and then just condense it. Do the same for the other canals, and this is your cold vertical compaction or your cold hydraulic obturation. Now, in cases of perforation, first of all, the perforations are very tough to manage because bleeding really bad. Our instruments are so big, plus we are not able to see what's happening. So, in this case, I told my patient that the prognosis of this tooth is really bad. Once I opened up and I saw the perforation is as huge as the floor, and I was sure that I'm going to have a vertical root fracture sooner or later. The patient was adamant, so we took a consent saying that this would not last, but on patient's compulsion, we are doing it. We went ahead and removed all the debris there. See, there's this one wall and floor which is involved. I always do the obturation first, induce slight fresh bleeding so that whatever debris is there, it gets oozed out. Take x-ray and check, then go ahead and pack MTA. Initially, when we do not have this putty consistency, of late we have putty, so it's very easy to pack in there. We do not have to sit and mix to a consistency to pack there. So initially, when we had this MTA and we had to mix, is to mix extra, pack in extra, and then remove the excess after 48 hours. But now with putty consistency, which is available with MTA with different companies, it's very easy to just make a ball out of it and pack it. So this is immediate post obturation x-ray, this is after 3 months, and this is after 6 months. So I see good amount of bone being formed at the furcation region. Periapical lesion is going away. So this gives, it gives you quite good amount of pleasure that yes, what we aimed for actually happened and we could do what was required. So I would like to end my presentation in 50 minutes because I never take full lectures. That's how it is. So the take home message, and I would take questions after this, is what is the take home message with magnification is, I would repeat again that if you have magnification, you are able to see things, a lot of things which I would have shown you, which you might have seen in textbooks, you would have thought you can do it, but if you have magnification, you can see them, you can diagnose them. There's sometimes that a case of bypass which I did, I'm sure even in the RVG it was not visible that there is an instrument which is broken there, but I could see it because I had magnification. Because of this, I have a better social standing and people look up to me for sending such cases because they know these kind of complex cases can be done by me. And I would be more than happy if you students or my colleagues reach that level and we start working at par with each other and we have better ideas of managing these and being as conservative as possible We can document them and we can share like this, discuss it like this, or we can put it across to our patients and show them, yes, this is how I'm going to be treating you, and this is the outcome, and you're going to be really happy about it. And we can send it for publications or discussions. So before I end my presentation, I would like to say this is the place where I did my graduation and learned my basics. This is where I did my post graduation, and Dr. Darpan is my colleague and co-PG in surgery. He's one person who's been doing really well, and I thank him for having me here for presenting here. This is where I did my advanced training in magnification, and Dr. Sushil would agree. Yes, this is where I taught a little I know to all my postgraduates. Now Sushil is a colleague now, not a postgraduate. He's a colleague, and this, this is please. I would want all of you to keep your mute because it's echoing to me. Please, yeah. Okay, and this is the place where I practice. But before I finish my presentation, I would always like to say that it does not matter how many resources you have if you do not know how to use them. So it's a very small example that he's having a staircase and he's using a heap of it to crawl over the wall, which he's not able to do. Whereas if he knew how to use this, so this is how our microscopes and magnifying loops are lying in the department. We do not use it until unless there is an inspection where we want to show them. But if you try to, they would be helpful to you. Always mute yourself, please. Can all of you mute yourself? I always give can you please mute yourself? Too much of disturbance. Can I have mute? Okay. So I always believe in this ideology that you should learn and you should teach, and always when you're teaching, you're always learning. So whatever little you know, if you pass it on to your colleague or to your junior or to your students, it's going to make their life better, and you are going to learn even more. So there is no internal competition which is going to happen. It's always going to improve your learning. So I would like to thank all my teachers, mentors, and friends. Before I end my presentation, I would want to show this small video. This is exactly how I felt when I joined Endo as a postgraduate, because I did not have so much of fascination towards endodontics. But then, just this small video, which I would want you to see. So I entered the department, and I felt that I don't exist there.
Yeah, of course. This is your room. I mean, you don't belong in the Jade Palace. You're a disgrace to Kung Fu, and if you have any respect for who we are and what we do, you will be gone by morning. Big fan. I see you have found a sacred peach tree of heavenly wisdom.
And this was a silver lining. That's my HOD who guided me through.
Sorry, I thought it was just a regular peach tree. I understand. You eat when you are upset. Upset? I'm not upset. Why makes you think I'm upset? So why are you upset? I probably sucked more today than anyone in the history of Kung Fu, in the history of China, in the history of sucking. Probably. 5. Man, you should have seen them. They totally hate me. Totally. How's Shifu ever going to turn me into the Dragon Warrior? I mean, I'm not like the 5. I've got no claws, no wings, no venom. Even Mantis has those thingies. Maybe I should just quit and go back to making noodles. Quit, don't quit. Noodles, don't noodles. You are too concerned with what was and what will be. There's a saying. Yesterday is history. Tomorrow is a mystery, but today is a gift. That is why it is called the present.
So what do I want to correlate here is, see, initially you might find yourself in a place where you didn't want to be. You might feel that you don't belong there. But there are going to be teachers and your HOD and colleagues and friends who would tell you, yes, you belong here, you can do things, and slowly things will start falling into place. So I would request all the PGs, interns, or finally graduates that don't lose hope. Even I did not know a single word in endodontics, but God has been kind. My teachers have been kind. My HOD, Dr. Vail Murugan sir, has been very kind on me that I could actually transform myself into what I am today. And whatever I am today is all because of my teachers, my friends, and colleagues. So, any questions you have, I'm ready to take it up now, or you can send it to me on any one of these contact details. So, coming to the end of my presentation, should I stop sharing my screen? Will that be okay?
Should I stop sharing my screen?
Will that be okay?
Yeah, you can stop sharing, Anuj. Yeah, you can stop sharing, Anuj.
Question answer session is going on. Can I interrupt?
Anuj, I thank you for the and we are fortunate to have Dr. Tyagi, College of Dental Sciences. This is very and I would like to over to Dr. Tyagi for followed by Dr. Tosh is who will be sharing the word of over to Dr. Tyagi.
Dr. Anuj.
Good afternoon.
Yeah, thank you so very much for making this happen in a very short notice. You are a well-known endodontist in Madhya Pradesh as well as in India, pan India. So thank you for sharing your knowledge, with our students, with your faculty and all. And looking forward again to, in person to PCDS very soon. Thank you so much.
Sure, ma'am, I would do it. And that has always been a guiding force, even in PG days. So it was my pleasure.
You're a part of. Thank you so much.
Good afternoon, everyone. I'm Dr. Santosh. Good afternoon, everyone. I'm Dr. Santosh. It's been my privilege that I've been asked to propose a vote of thanks. First of all, would like to thank from our chairman, Dr. Sri Suresh Vijayvargi sir, Ms. Neha Vijayvargi, Director People's Group, Mr. Rohit Pandit, Managing Director People's Group, our Vice Chancellor, Dr. Rajesh Kapoor, Director Academics, VK Pandya sir, Registrar Nirja Malik ma'am. Special thanks to our Dean, Dr. Panimala Tyagi ma'am, Vice Dean Dr. Swapnil Parlani for continuously supporting us. And I'd like to thank our HOD, Dr. Manish Agrawal sir, Academic Coordinator Dr. Darpan Bhargav and Dr. Tilok Srivastav, my department staff and colleague Dr. Anu Narang ma'am, Dr. Pankaj Mishra, Sushil Kisnani and other staff. And I like to thank Dr. Anuj, special thanks to Dr. Anuj Bhargav for such a wonderful presentation and sharing his thought and knowledge with us. We look forward for many more interaction in coming days with you and want to have a strong association with you in near future. Last but not the least, all the invitee guests who have spared their valuable time for this presentation. Thank you one and all for all this wonderful presentation. Thank you. Thank you.
Thank you, Dr. Santosh. Always meeting.
Thank you. Thank you, Anuj. Thank you. It's a wonderful presentation. Thank you very much.
Thank you, Anuj, for thanks a lot. and it was in fact a pleasure. We already have started getting feedbacks from and kind of an eye opener for them. And it is again a request that the postgraduates in endodontics requesting for a more detailed vision into the subject, and we will get in touch with you on and off and very frequently henceforth, so that at least we can inspire a few of them. And
Sure, Doctor. We'll do that. That one we'll do that. We can always have a hands-on with them. We'll
Yes,
make
yes.
sure that they get into it and they start using it. There is no second thought in it.
Right. Thank you. Thanks a lot. And it was a wonderful afternoon we had together. Thank you Anuj, for sparing time.
Good afternoon, Anuj. Hello, good afternoon. And actually, we're just waiting for one photo. Just please wait. Ma'am is just joining.
Yeah.
संतोष कैसे हो भाई?
Can we disconnect now?
No. 1 minute, doctor. 1 minute,
Yeah.
just. Laptop tha.
Dr. Slok is trying to get all of us on the screen so that we can have a snapshot of the screen at least on this virtual platform.
I've done that for you.
No,
I'll send it to you, Doctor.
Chalo. Thank you. Thanks a lot.
Bye-bye. Take care. Good day. I'll talk to you. Yeah.